Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about malignant melanoma. Definition: Malignant melanoma is a cancerous neoplasm or pigment-forming cells, melanocytes and nerve cells. Clinically, its hallmarks are an irregular shape and colored macule, pupule or plaque. Four types of melanoma are recognized: superficial spreading, Lentigo Maligna, Nodular and Acral Lentiginous. Incidence: the occurrence of malignant melanoma is increasing faster than that of any other cancer in the United States, with increased sunlight exposure implicated as one factor. More than 100,000 new cases of melanoma are diagnosed yearly in the United States. The estimated lifetime risk of developing a malignant melanoma is approaching 1 in 38 for the white population, 1 in 167 for the Hispanic population, and 1 in 1,000 for the black population. History: an increase in the size of the lesion or a change in its color is noted by most patients who have melanoma. Development of new growth, bleeding, and itching are other symptoms that may accompany a melanoma. Occasionally, patients have a family history of malignant melanoma. Physical examination: Lentigo Maligna melanoma, superficial spreading melanoma, and Acral Lentiginous melanoma are characterized by a horizontal growth phase that allows for clinical identification before deeper invasion and metastasis occur. The ABCDEs or identifying characteristics for these three types of melanoma are asymmetry, border irregularity, color variegation, diameter greater than 6 mm, and evolution. The suspicious lesion is red, white, black, dark brown, and blue, has a notched border, and may have a pupule or nodule within it. However, in approximately 10% of melanomas, the ABCDE rule does not apply. Therefore, any pigmented lesion or nevus that looks significantly different from an individual's other nevi or the ugly duckling mole should be viewed suspiciously and biopsied. Lentigo Maligna melanoma occurs on sun-exposed skin, especially the head and neck. It is multicolored with dark brown, black, red, white, and blue hues, and it is elevated in areas. It is preceded by Lentigo Maligna in situ melanoma, which extends peripherally and is an uneven, pigmented, dark brown and black macule. Lentigo Maligna often reaches a diameter of 5 to 7 cm before showing signs of invasion. The change in size and darkening are insidious, occurring over a period of years. Lentigo Maligna melanoma, large brown, black, regularly shaped macule that typically occurs on the face of the elderly. The most common type of melanoma is the superficial spreading melanoma. This lesion is irregular in color: red, white, black, dark brown, and blue. Surface macule, pupule, or nodule, and border notched, and may occur anywhere on the body. It is found most frequently on the chest and upper back in males, and on the upper back and lower legs in females. During the horizontal growth phase, the lesion is flat, extending and approximately 2.5 cm in diameter before invasion develops. Superficial spreading melanoma, brown, black, regularly surfaced and bordered plaque with a red pupule. Nodular melanoma is a rapidly growing blue-black, smooth or eroded nodule. It occurs anywhere on the body. It begins in the vertical growth phase, so is less likely to be diagnosed in a premetastatic stage. Nodular melanoma, blue-black nodule. In epidermis, atypical pigmented melanoma cells is present. In epidermis, variously raised nests of atypical melanoma cells, and inflammation is present. Acral Lentiginous melanoma occurs on the palms, soles, and the distal portion of the toes or fingers. It is an irregular, enlarging black growth similar to the Lentigo Maligna melanoma, but much rarer. The vertical growth phase in this type of melanoma can be deceptive, showing only a small degree of papular elevation associated with a deep invasion. Acral lentiginous melanomas have no relation to skin phenotype, occur at equal rates across ethnicities, and are not induced by UV exposure. However, they account for a higher percentage of melanoma diagnosis in darker skinned patients, while making up less than 1% of melanomas in fair skinned patients who are more prone to sun-induced melanoma subtypes. Acral lentiginous melanomas are diagnosed and treated at later stage in black patients, likely due to the lack of social campaigns aimed at raising awareness of melanoma in dark skin, coupled with the relative lack of efficacy of available immunotherapies, which are more effective in sun-induced melanomas. Acral lentiginous melanoma on the soul, black, brown, and whitish, irregularly shaped and bordered plaque with an erosion. Differential diagnosis. Although the clinical criteria outlined above allow for the early diagnosis of malignant melanoma, other pigmented lesions must be considered before definitive therapy is undertaken. In one study, 2/3 of the pigmented lesions that were thought clinically to be malignant melanoma were not malignant by histopathologic criteria. The differential diagnosis of lentigo maligna melanoma includes actinic lentigo and seborrheic keratosis. The brown color of these later lesions is a reassuring sign of their benignity. Pigmented basal cell carcinoma, seborrheic keratosis, nevus, and angioma can look like superficial spreading malignant melanoma. Nodular melanoma can resemble pyogenic granuloma, angioma, blue nevus, and dermatofibroma. A pyogenic granuloma is an easily bleeding nodule composed of numerous benign blood vessels. It often occurs after minor trauma and can be viewed as excessive granulation tissue. Tinea nigra palmaris, a rare superficial fungal infection, and nevus should be considered in the differential diagnosis of acral lentiginous melanoma. Tinea nigra palmaris can easily be diagnosed with a potassium hydroxide scraping that reveals fungal hyphae. The conclusion of differential diagnosis of malignant melanoma include lentigo maligna, actinic lentigo, and seborrheic keratosis, and for superficial spreading is pigmented basal cell carcinoma, seborrheic keratosis, angioma, and nevus. And for nodular is a pyogenic granuloma, angioma, blue nevus, and dermatofibroma. And for acral lentiginous melanoma is tinea nigra palmaris and nevus. Biopsy. All suspicious pigmented lesions must undergo biopsy by excision with narrow 2 to 3 mm margins of normal skin or by deep shave biopsy. Definitive treatment by wide surgical excision should not be undertaken until confirmation of malignant melanoma has been made histologically. For extensive lesions such as lentigo maligna melanoma, it is acceptable to perform an incisional biopsy before definitive therapy. The histologic features vary with the type of melanoma and require a skilled pathologist for interpretation. Gene expression profiling is used in selected lesions for diagnosis, atypical nevus versus melanoma, and prognosis of melanoma. Note, all suspicious pigmented lesions, especially the ugly duckling mole that could be a melanoma, should undergo excisional or deep shave biopsy. Therapy. The survival of patients with malignant melanoma depends on early diagnosis, when surgical excision is often curative. The margin of normal skin excised around the melanoma increases with the depth of invasion or thickness. In situ 0.5 cm margin, thickness less than 2 mm 1 cm margin, and thickness equal to or more than 2 mm 2 cm margin should be excised. Note, cure of malignant melanoma rests in the hands of the surgeon if the lesion is treated early enough. Radial lymphatic sentinel node mapping and biopsy have been used for melanomas deeper than 0.8 mm in thickness in patients with clinically negative lymph nodes. A radioactive tracer is injected at the site of the primary melanoma before a wider excision is performed. The first draining or sentinel lymph node can be identified by lymphoscintigraphy and examined by biopsy for the presence of metastatic melanoma. In this way, the surgeon can identify patients who may benefit from adjuvant immunotherapy. Prognostic information is also garnered. Note, sentinel lymph node biopsy is an appropriate staging procedure. Its survival benefit is controversial. Once a malignant melanoma has metastasized, several therapeutic options are available and best managed by a medical oncologist familiar with these agents. Immunotherapy, kinase inhibitors, chemotherapy, radiation, and oncolytic viruses. Radiation therapy is used for palliation of bone and brain metastasis, and when Lentigo Maligna is so large that surgical removal is technically difficult. Chemotherapy or dacarbazine has a limited effect and its role is diminished. Immunotherapeutic approaches for the treatment of disseminated or inoperable melanoma are preferred, especially the immune checkpoint inhibitors, which include cytotoxic T lymphocyte-associated antigen 4 or CTLA4 blocking antibody like ipilimumab and programmed death receptor 1 blocking antibodies like nivolumab and pembrolizumab. Cytokines interleukin 2 are less frequently used. Targeted therapy or kinase inhibitors like vemurafenib, dabrafenib, and trometinib, and combimitinib, and biologic agents like telimogen, lahir-paripwak have caused significant response rates. However, they are not usually long-lasting as a solo therapy. Now, the mutations BRAF, MET, KIT, and NRAS, PTEN provide therapeutic signaling pathway targets for their inhibition of melanoma growth. The conclusion of therapy for malignant melanoma. Initial therapy include wide excision with margins of normal skin based on thickness of melanoma, in situ 0.5 cm margin, thickness more than 2 mm 1 cm margin, and thickness equal to or more than 2 mm 2 cm margin should be excised. An alternative for metastatic or inoperable melanoma include immunotherapy or immune checkpoint inhibitors and kinase inhibitors like targeted therapies and oncolytic viruses, chemotherapy, and radiation. Course and complications. Lentigo Maligna melanoma, superficial spreading melanoma, and Acral Lentiginous melanoma initially have a horizontal growth phase manifested as a macular or slightly raised pigmented lesion. During the horizontal growth phase, malignant melanoma is curable. Nodular melanoma has only a vertical growth phase which forebodes a worse prognosis. Pathologists Wallace Clark and dermatopathologist Alexander Breslow correlated survival with tumor thickness. Clark and co-workers devised a system of microstaging melanoma based on the level of invasion in the dermis. The difficulty with this system is variability in differentiating between level 3 and level 4 melanomas. Breslow, using an ocular micrometer, measured tumor thickness from the stratum granulosum to the depth of invasion. These measurements are reproducible and are the preferred methods of calculating tumor thickness and thus of predicting 5-year survival. Survival is related to the depth of invasion. It is estimated that patients with melanoma have a 5% chance of developing a second one. Extensive laboratory tests such as brain, bone, liver, and spleen scans, magnetic resonance imaging, or positron emission tomography are not indicated unless the history of physical examination suggests possible metastasis to these organs. Note, certain principles are important concerning malignant melanoma. A horizontal growth phase makes surgical cure possible for superficial melanoma. The prognosis is related to tumor thickness, and clinical criteria allow for an early diagnosis of malignant melanoma. Guidelines for recommended follow-up of patients with malignant melanoma. New or changing mole review of symptoms, examine complete skin surface and lymph nodes, more extensive studies based on patient symptoms and signs, and follow-up visit every 6 months for 2 years and then annually. Pathogenesis. The pathogenesis of malignant melanoma is unknown. However, sunlight or sunburn, indoor tanning, and hereditary CDKN2A and CDK4 gene mutations have been implicated as risk factors. Other risk factors for melanoma include a large number of small nevi, a larger nevi, and dysplastic nevi. The production of melanoma by UV radiation is suggested both epidemiologically and experimentally. The cause and effect relationship, however, is less well proven than with other skin cancers. Familial occurrence of malignant melanoma is rare but well established. The familial atypical mole and melanoma syndrome or dysplastic nevus syndrome or BK mole syndrome occurs in family members with numerous atypical appearing haphazardly colored and bordered nevi or atypical moles and who have one or several malignant melanomas. Note: familial atypical mole and melanoma syndrome should be suspected if personal or family history of melanoma and numerous or more than 50 atypical nevi is present. Biopsy of these atypical moles reveals disordered melanocytic proliferation. These atypical moles are markers for an increased risk of developing malignant melanoma and, in some cases, precursors of melanoma. This syndrome occurs sporadically and in familial pattern. Close clinical follow-up and biopsy of suspicious nevi are mandatory. Genetic testing may be considered when 3 family members have melanoma. An individual has 3 melanoma or 3 cancer events. Melanoma or pancreatic cancers occur in a family. Note: rule of threes for familial melanoma genetic testing. 3 melanoma is in a family, 3 melanomas in an individual, and 3 cancers, melanoma or pancreatic, in a family is present. Clinical case: a 46-year-old man presents with a changing pigmented lesion on his upper back. He reports that the lesion has been present for many years but recently noticed that it has increased in size, become darker, and developed irregular borders over the past 3 months. He also reports occasional itching but no bleeding. On examination, there is a 1.5 cm asymmetric dark brown to black macule with irregular borders, color variation, and an area of red pigmentation. Dermoscopy shows a typical pigment network. Which of the following is the most likely diagnosis? A. Seborrheic keratosis. B. Dermatofibroma. C. Junctional nevus. D. Malignant melanoma. And E. Blue nevus. According to our explanation, it's obvious that the diagnosis here is malignant melanoma. Explanation: malignant melanoma should be suspected when a pigmented lesion shows the ABCDE warning signs, which A is for asymmetry, B is for border irregularity, C is for color variation, which is brown, black, red, sometimes white or blue, and D is for diameter more than 6 mm, and E is for evolution, which is change in size, shape, color, or symptoms. Differential points: seborrheic keratosis is stuck on waxy varicose surface without evolution. Dermatofibroma is firm nodule with dimple sign on lateral pressure, and junctional nevus is symmetric, uniformly pigmented and stable lesion, and blue nevus is uniform blue-gray pupil without changing. Okay, this was an explanation about common types of malignant melanoma. Thank you for your attention.